Hi students, this is Dr. Tatum. I believe I was cut off when I was talking about nutritional history, so I'm still on slide 12. With nutritional history, it's really important to figure out her current dietary practices. So what is her daily intake? Does she have any food allergies that we need to make note of? And also, is her nausea and vomiting so bad that she's just not able to absorb enough nutrients at this point in time? That's something else that we need to question just because morning sickness can be really terrible in that first trimester. So, finding out more about her symptoms is also pertinent. Also, asking about pica, which is a nutritional deficiency, is important. We can't come out and say, do you have pica? But we could ask her if she craves any non food items like clay, ashes, dirt, anything out of the ordinary that would cause us to be suspicious. If she's not gaining enough nutrients, then she can sometimes suffer from these nutritional deficiencies like pica. So asking appropriate questions about just nutrition in general is going to be a good guide for us to go off of, especially as we are getting baseline assessment data in our patients. Asking about history of drug abuse or substance use is important. Finding out what age, if she has used before, what type of illegal substance was it, what reactions she had, how long was she abusing these illegal substances. Also, does she have any herbal preparations that she takes? Finding out this information is important just because we know that herbal products can interfere with different drugs, any prescription drugs and over-the-counter drugs. And we know that herbal preparations can sometimes cause teratogenic effects in the fetus. So finding out what products she is using is important so we can educate her appropriately. We'll move on to slide 13 here. So as I said before, family history is really important for the woman, but also asking about the father of the baby's family history might be crucial. So if there's any specific family history complications that we need to make note of, we should. So if there's a history of Down syndrome, if there is any history of spina bifida in his family, anything out of the ordinary that would cause us to think, oh, well, maybe we should write that down. Maybe mom is at higher risk for carrying a fetus with this type of disorder. Finding out about social, experiential, and occupational history is also very important. Just what is their ethnic and cultural background? What are their values? What are their preferences? Even finding out more about the history. Was this a planned pregnancy? So is this something that they're both very excited about, or is this an unplanned pregnancy that causes more apprehension? And maybe they just don't know how they feel about this pregnancy in general quite yet. Any problems with finances? Do they have adequate insurance even? And does mom have an adequate support system in place to help her throughout this 9 months of pregnancy, but also into that postpartum period? Also, asking about history of physical abuse is really important just because the chances or the likelihood of abuse occurring during pregnancy is quite high. We're going to talk a little bit about domestic violence and domestic abuse later on in the semester, but just know that the risk of abuse increases during pregnancy. Doing a review of systems is important. We want to find out any pre-existing problems that could be existing. Finding out baseline data through physical exam and basically writing down height, weight, vital signs routinely is important. Gaining a urine specimen on the patient is also really important just because a urine specimen can tell us if there's any protein, leukocytes, any glucose in the urine. All of those things can reveal certain diseases to us, and just getting a urine specimen on every prenatal visit is something that will likely occur. Other laboratory tests that are done during this initial visit is a CBC, so a complete blood count. We're looking at blood type and Rh factors. Doing a rubella titer so we know if she is rubella immune or non-immune is important. Doing an HIV screening test is also very important and should be documented. We're also going to be assessing her kidneys and her renal functioning. So looking at uric acid, we're looking at BUN and creatinine levels in her urine. That's also important. Some women will have to have a pelvic exam, and most women will, I will say, in that first initial visit. So what they'll do is they'll do a pelvic exam, and they'll also do cervical and vaginal smears, just to assess for any sexually transmitted diseases like chlamydia or gonorrhea. That's usually done in that first prenatal visit as well. Sickle cell screening might be done for African, Asian, and Middle Eastern descent individuals, just because we know that the risk for sickle cell anemia is quite high in those ethnic groups. So that's something else that might be done on that first initial visit. We're going to move on to follow-up visits. So remember, we talked about just the routine prenatal exams, and remember that these prenatal visits occur monthly throughout the first and second trimester. And then at 28 weeks or so, that's when she starts to see the doctor every 2 weeks. And then at 36 weeks, it's usually done weekly. So usually weekly throughout the remainder of pregnancy at about 36 weeks gestation. So these follow-up visits, a lot of times during the interview process, we have her summarize any events that took place since the last visit. We ask her about her emotional and physical well-being. Does she have any complaints or concerns at this time? We also do a physical exam. The blood pressure is routinely taken on the same arm at every visit, and usually the woman is in a sitting position. We also ask about weight, and we document her weight. So we want to know the amount of weight gain at each visit. Urine is routinely checked as well with a dipstick. And so again, we're assessing for protein, glucose, and leukocytes in her urine. We assess for any edema that she has. So edema in her lower extremities. Does she have edema in her fingers or her hands? Does she have edema across her face? So all of those things we are assessing. And the practitioner will also measure the height of the fundus, which we'll talk about here in a minute. With fetal assessment, we always assess fetal heart tones. And so a lot of times with a Doppler or so, a Doppler ultrasound, the nurse or even the practitioner will document a baseline fetal heart rate. So that's always exciting to hear for mom when she goes into her visits. She gets to hear her baby's heart rate, and that sometimes eases that concern and worry that she may have. The fundal height is usually done during the second trimester of pregnancy because this is when the uterus becomes an abdominal organ. So usually from 18 to 32 weeks, the height of the fundus is measured in centimeters, and it's approximately the same as the number of weeks gestation, give or take 2 weeks. So either 2 weeks, 2 weeks more than what she currently is, or 2 weeks less than what she currently is. Usually when we measure the fundal height, it's done with her having an empty bladder, just because we're going to be pressing just gently, but it can be kind of uncomfortable for her. But usually we measure from the symphysis pubis all the way to the top of the fundus. And on the next slide, you're going to see some pictures that show a practitioner measuring the fundal height. We also look at gestational age. So again, a lot of times we can tell a lot by gestational age by doing an ultrasound. And so an ultrasound can tell us the number of weeks gestation. It can tell us the estimated date of delivery, and it can also tell us the biparietal diameter of the fetal head. So we can tell a lot more with ultrasound, but then we also compare ultrasound to what we're getting for our fundal height measurements to make an accurate account. As far as the health status, we want to ask mom if she has been feeling baby move around. Does she feel those movements fairly regularly? And also, again, we're measuring the fetal heart tones at that visit, and that will also give us a good indication of fetal well-being. So let's move on. And this is a picture of a practitioner measuring the fundal height. So you can see she's measuring from the symphysis pubis all the way to the top of the fundus. All right, this next slide shows just different listening devices that can be used to hear fetal heart tones. So letter A shows you a father listening with a fetoscope, and this fetus is about 18 to 20 weeks gestation. B shows you a Doppler ultrasound, and this Doppler ultrasound is probably what you're going to see most commonly in practice. A lot of times you don't see a fetoscope used in practice. Sometimes a midwife will use a fetoscope, but a lot of times a Doppler ultrasound is what you're going to see. And this last picture shows a Pinard fetoscope. And so the hands don't touch while listening because that can interfere with just the tones being produced. All right, let's move on and let's talk about other laboratory tests. So the multiple marker or quadruple screen blood test may not be routinely done by the doctor. Sometimes the doctor just may recommend this because this is the screening tool used for Down syndrome as well as neural tube defects. So if there's a history of Down syndrome or if mom's age is a little bit higher than what a practitioner would like it to be. So maybe she's a geriatric pregnancy patient. So maybe she is over 35 or over age 35 or 36. That's when they might say, you know, have you thought about this? We could detect if Down syndrome is present. What are your thoughts on this? Based on your age, what would you like to do? I actually had this when I was pregnant with Emma because I was 35 when I had Emma. And my husband and I decided that we didn't really need to know either way. But there are lots of parents that would want to know if they had a child that had Down syndrome, just to prepare themselves and just to really talk about some of the concerns of Down syndrome and what life might be like for them as well as their child. And so some patients want to know right away, others do not. But usually if this is done, it is recommended between 15 and 20 weeks gestation. Ideally, it should be done between 16 and 18 weeks gestation. Other blood tests would be the rapid plasma if I can talk, the rapid plasma reagent, and that screens for syphilis. So that you can see VDRL is syphilis. Also, we talked about CBC, and we also wanted to know what Rh antibodies were present. Other tests would be ultrasound, and then an amniocentesis can be done when we check amniotic fluid. We can test for different genetic disorders through amniotic fluid, and we can also assess gestational maturity level. So we can tell a lot about the long maturity through an amniocentesis, which is kind of nice as well. All right, usually right about between 24 and 28 weeks gestation is when the patient will have a 1-hour glucose tolerance test. So they basically check her blood sugar after she's been fasting and after she drinks a very sugary substance. If she doesn't pass that 1 hour, she'll have to move on to do a 3-hour glucose tolerance test. And we're going to talk more about that when we talk about diabetes with pregnancy. But just note that that does occur between 24 and 28 weeks gestation. Usually we also check for group B strep between 35 and 37 weeks gestation, and we do a vaginal rectal swab to check for group B strep bacteria. All right. Moving on, I think what I'll do is I'm going to stop there because I know my time is coming up and I will continue with my next recording. All right, thank you.